This X-ray shows the classic coffee bean sign of a sigmoid volvulus. We have an 80-year-old patient with massive colonic distension, but their vitals are stable and there are no signs of peritonitis. Despite the massive dilation on the screen, a stable exam means we prioritize flexible sigmoidoscopy for controlled detortion over an immediate laparotomy. Contrast that with this X-ray showing a sequel volvulus, where the dilated loop cross-over into the left upper quadrant. This typically presents in a younger, 35-year-old patient with acute colicky pain. The anatomical shift and patient demographic change the rules entirely. Endoscopic reduction fails here. This presentation demands an emergency laparotomy. Now look at a patient with ulcerative colitis, bloody diarrhea, and tachycardia. The colon expands past 6 centimeters, signaling toxic megacolon. The immediate treatment requires bowel rest, IV fluids, and corticosteroids to reduce the inflammation. Attempting a colonoscopy or enema to assess the mucosa at this stage is a dangerous error, as the thinned, paralyzed bowel wall is at a high risk for toxic perforation. These 3 cases establish the baseline rule of the acute abdomen. Endoscopic management is reserved for patients who are structurally stable and non-toxic. The moment ischemia, perforation, or systemic toxicity appears, conservative options end, and surgical or aggressive medical decompression takes over. When an adult presents with classic right lower quadrant pain and an intermediate Alvarado score, the historical reflex was to rush straight to an appendectomy. Modern standards require an abdominopelvic CT scan to confirm the inflammation before making an incision. There is a critical exception to that imaging rule. If a pediatric patient has right lower quadrant pain triggered by palpating the left lower quadrant, a positive Rofsing sign, avoid the radiation of a CT scan. For children and pregnant women, ultrasound is the required diagnostic tool. This flowchart shows acute diverticulitis progression. Uncomplicated presentation requires only oral fluids and antibiotics, but a complication like a 5-centimeter abscess branches the pathway into IV antibiotics and potential drainage. An abscess greater than 4 centimeters dictates CT-guided percutaneous drainage. For localized lower GI infections, the default modern action relies on image-guided drainage and targeted antibiotics. Surgical intervention is held in reserve for when drainage fails or the patient develops generalized peritonitis. This CT scan shows severe gallbladder disease. Standard acute cholecystitis can wait 72 hours for cholecystectomy, but here, an air fluid level and luminal gas in the gallbladder wall indicate emphysematous cholecystitis. In a adenodiac with crepitus, this requires emergency surgery and Clostridium coverage. If the infection moves to the bile ducts, the timeline accelerates. A patient exhibiting Raynaud's pentad, fever, jaundice, right upper quadrant pain, hypotension, and confusion has acute cholangitis. A simple cholecystectomy will not fix the obstructed duct. You must perform an ERCP within 24 to 48 hours to establish biliary drainage. Pancreatitis management plays out over a much longer timeline. You diagnose it initially with biochemical markers and an ultrasound to check for gallstones. If the patient deteriorates around day 7 with fever and leukocytosis, a CT scan is required to identify infected pancreatic necrosis for antibiotic treatment. This CT scan shows a complication appearing around week 4. Notice the well-defined, thick fibrous capsule containing a 6-centimeter fluid collection in the pancreatic bed. This is a mature pancreatic pseudocyst. If it causes symptoms like mechanical obstruction or abdominal pain, it requires endoscopic drainage. The upper quadrant pathologies operate on distinct clocks. Infected obstructed bile is a 24-hour endoscopic emergency. Severe pancreatic complications develop over weeks and require highly specific, delayed image-guided interventions. When a lethargic patient presents with massive upper GI bleeding and continued hematemesis, do not reach for the endoscope first. Their depressed level of consciousness puts them at high risk for aspiration. The absolute first priority is securing the airway with endotracheal innervation. This algorithm details the variceal hemorrhage sequence. You secure 2 large-bore IVs for volume resuscitation, administer octreotide and antibiotics, and attempt urgent endoscopic therapy. If the bleeding continues, you deploy balloon tamponade as a temporary bridge while awaiting a TIPS procedure. Lower GI bleeds demand different branching logic. Episodic, painless, dark maroon stool in an adult points to right-sided angiodysplasia. But if the patient is passing massive amounts of bright red blood and becomes hemodynamically unstable, you suspect a severe upper GI bleed transiting rapidly through the gut and perform an upper EGD. Postoperative vascular complications are stealthy. Persistent, unexplained tachycardia in a patient recovering from a gastric bypass is an anastomotic leak until proven otherwise. A patient developing bloody diarrhea shortly after an aortic aneurysm repair is showing the classic signs of watershed ischemic colitis. In a small bowel obstruction, the management plan flips based on physical findings. A conservative approach of NG tube decompression and IV fluids is immediately abandoned for an exploratory laparotomy the moment the patient develops focal guarding, rigidity, and a rising lactate level indicating bowel strangulation. This X-ray shows a premature neonate with biliosemesis. Linear branching gas in the liver and train track lucency in the bowel wall indicate pneumatosis intestinalis, the hallmark of necrotizing enterocolitis. While broad-spectrum antibiotics are started, free air under the diaphragm dictates immediate surgery. Across every GI system and patient demographic, the rule remains consistent. Hemodynamic instability or the appearance of new ischemic markers immediately overrides standard diagnostic sequencing. It forces you straight to invasive control. These 5 triggers demand immediate action. Unstable bleeder, airway first. Peritonitis or free air, open abdomen. Obstructed, infected bile, ERCP right now. Pus over 4 centimeters, drain it. Post-op tachycardia, it is a leak. Managing the acute abdomen relies on identifying the exact threshold where a stable patient decompensates, using the trend of the vitals and the findings on imaging to pinpoint the moment a medical case becomes a surgical one.